Good morning, DHA staff and everyone who's joining us via VTC. I want to welcome you. Anyone who's joining us from overseas, good afternoon. My name's Ann Edgecombe. I am the Chief of Internal Comms, and this is our quarterly town hall. General Place will come in just a moment and kick things off. I wanted to remind everyone that we do have a way for you to ask questions. During the town hall, if you're in the room, obviously you can raise your hand and wait for us to bring a microphone to you. If you're not in the room, you can, if you're in the VTC world, you can actually take your VTC off mute and ask a question that way. And then if you want to ask it through our Poll Everywhere app, you can do that. The information is on the calendar invite. We also have it posted here in the room. You can go to www.pollev, that's POLLEV.com/WFD guest. So again, that's on the calendar invite. And I think that's it. If you're in the room, please silence your phones. And I think we're ready to get started. Command Master Chief.
Attention on deck. Good morning, everybody. Please take your seats. So I like the intimate setting. It's interesting that we're closer together when perhaps there's more fear. So sometimes what we do doesn't make as much sense as we'd like it to. So I have a few charts. I know there's a number of people who are watching and not here inside the room. So I'm going to do my best to remember which chart that we're on. There's only, I think, 7 or 8 of them. There's very little words on them, which is, for those of you who've been at my presentations before, you know that I don't like words on. I'm not smart enough to read and listen at the same time. So mostly you're going to see some images for me. Secondarily, this deck changed yesterday and again this morning. And so I will tell you that my practice of how this is going to go isn't as good as I normally like it to be. So if it looks like I'm just a little bit not up to speed on my own deck, it's because my deck continues to change, because the world's changing. So I'm hopeful that you'll cut me just a little bit of slack for my presentation and the preparedness that went into the preparation of this presentation, because it is a relatively fluid environment. Okay, so first thing, let's go on the next chart. So for those of you who are watching, this is the chart that shows our new coin for the organization. And so congratulations to Major Robert Baldwin from the 88th Medical Group at Wright-Patterson Air Force Base. It's his coin that we've selected, and in fact, not only has it been selected, but it's been sent to a design team who worked with us to change it just a little bit to make it such that they could actually manufacture it, and we received it yesterday afternoon. So if you're going to get a coin from me for the next, let's say 2 years and 6 months, it's probably going to look like this. And in fact, I have one of these bad boys in my pocket today. So there may be an opportunity, even today. The first one has been set aside for Major Baldwin, but there may be opportunities. Now, here's the good news. There's a lot of creative people in the Defense Health Agency and across the military health system, both from this headquarters and other DHA locations, so San Antonio, Aurora, et cetera, along with MTFs. We had more than 50 coin designs submitted that ultimately led to this selection. So if you're wondering, man, how did this coin, that's really cool looking coin, how did you come up with it? Because there's an awful lot of talent. So my thanks to everybody else who submitted a coin for consideration that wasn't chosen, but we have this. Okay, let's go to the next chart. Anybody know what this is? So everybody knows what this is, right? Third chart, it's a color picture of the coronavirus. And I'm just telling you, if you think it's fluid today, it's going to get even more fluid in the next, 2 to 4 weeks or so. And then it's likely to become a lot more stable. We'll know what we're dealing with. We'll know what we're doing. Policy, process, et cetera, will be updated for how we collectively, the United States, how we collectively, the interagency, how we collectively, the Department of Defense, and how we collectively, the military health system, will be responding to the challenges that come from this little bad boy. The pressures on the interagency are relatively significant now. Right? And are some of you feeling that pressure? Yeah, that's okay to feel the pressure. But it also, at least in my mind, it signifies the importance of what the rest of the world, but specifically America, thinks about the Department of Defense. I mean, we're the go-to guys when there's travesty around the world. Is that right? I mean, that's a fact. It doesn't matter where it is. There can be a tsunami somewhere or a hurricane, right? Earthquake. Who do they ask first? Around the world. Well, that's for the United States. And what part of the United States? It's us, right? Okay, so now this is an international thing, but for our government, this is a intra-United States thing. This is us supporting the rest of America. And again, I mean, this is an interagency, and we're following from an information guideline perspective, we're all following the CDC. And the specific lead element for response for the United States is what organization? Do y'all know? HHS, Health and Human Services, but who's the key supplier of manpower, of equipment, whether it be durable equipment or disposable equipment? Who is it, do you know? It's the DOD. I mean, we are the easy button for just about everything. So just expect more is going to be coming our way. And our job, of course, is to balance how we support the interagency in the response for America to this particular challenge, but to never lose sight of our mission set, and that's support of the National Defense Strategy. So I want to help every single American. I do. But if that makes us vulnerable as a country, we should be having serious conversations about, is that something that we want to give up? So that's our responsibility, in particular in the DHA headquarters, to balance all that. So as you're getting requests for information, please do your best to fulfill them, because we want to be able to support America. We want to be able to support the interagency response. But we must remember our number one mission, and that's support the warfighter. Keep our country safe. Balance that, okay? And if you need to remember or have anything, then put up a little photo of this particular virus. Now, how do we handle things internally? Now, we're going to make all kinds of decisions. Most of them are going to be good. Some of them probably not, because we're humans, right? And we're going to make fast decisions on limited information. Some of them are going to be not perfect. Get over that. It's the way it's going to be. And we'll address them, and we'll update them, and we'll admit that we're wrong, because most of them will probably be my fault. And then we'll move on from that. But what we're not going to be is we're not going to be complacent. But we're going to pay attention to detail. We're not going to be scared. We're going to be informed. We're going to be vigilant. And we're going to be smart. But we don't live in a risk-free world. So it's all about balancing that as we do our mission in support of the National Defense Strategy. And if you have questions about this, please don't ask them now, but keep them on the top of your mind or write them down, notes or something like that, and I'll answer those when I get to the rest of, or through the rest of this presentation. Let's go to the next chart. So what I wanted to talk about is the ongoing transition, because really that's the major line of effort of the military health system. And I like this cartoon. Wasn't developed for us, so what chart number is it? Do you know, is it 4 or 5? 4, it's chart 4 for those of you who have them. But it's a cartoon that's a sort of us versus them cartoon. And depending on where you see yourself, and the way I talk about it when I'm out at MTFs, on the barbarous wastes, the bad guys, that's us in the DHA, and our blessed homeland, that's whatever service you in, it's whatever MTF you happen to be in. But here's the challenge, in particular for the uniform staff. There's going to be times when you're going to be assigned to the DHA. So what part of that cartoon are you in? Because if you think that in your service you're part of the blessed homeland and then you get assigned to the DHA, does that make you on the bad guy team? Or if you're one of the civilian personnel who's been working in, you'd name the service, Department of the Army, Department of the Air Force, Department of the Navy, and now you're transitioning through a transfer of function or a mandatory reassignment type thing, does that mean that you're getting sent to the evil wastelands? Is that really what that means? Or, the way that I see it is, we've had really great systems, and this is a time of significant transformation, and it's our natural reaction to be resistant to monumental change. And we have to get over that. And the only way to do that is if you really look at this cartoon, it's really exactly the same on every side. Now, the colors are a little bit different, but other than that, it's the same. And that's the fact, Jack. If you look at the way Air Force MTFs are managed and the health care that's delivered in them, or Army MTFs are managed and the health care that's delivered in them, or Navy and Marine Corps MTFs, guess what? There are some minor differences, hence the little color changes on this cartoon. But the huge majority of what's happening in there is the same. And we just have to get over this fact and come together to be on the same team as we work our way through the transformation. So if any of you want to use this cartoon, I don't know where our guys got it. I think there's no rights associated with it, and we can share it widely. Is that right? Yeah, use it however you want, this particular thing. But transformation has to continue to go on. Whether it's COVID impacting the resourcing that we have or anything else, transformation has to go on. Now, the trouble with transformation is, does the mission get lost in it? So I like this photo. This is photo 5, and on the left side of the photo, it's got a bunch of airborne qualified personnel in the back of Air Force aircraft, and on the right side, it's got a surgical team. Now, on the left side, can you tell, those of you who can see the charts, can you tell, is this 82nd Airborne Army personnel? Is this, are these Navy SEALs? Is this a group of Air Force pararescue jumpers? Can you tell? Yeah, well, maybe some of you can. Most of us can. Now, if you can really get close enough to uniforms, there are ways to tell, and I'll grant that. But we've moved the photo away long enough so that, or far enough away so most people can't tell. But this, can you tell if this is a training jump or if it's a mission, an operational mission? You can't, but the second question is, does it matter? And that's the fact. It doesn't matter. That's what we're here to support. Because every training mission is in support of being more ready for the operational mission. And so our role, and in the longer version of this presentation, I go through them, but our role is to make sure that everybody who's supposed to be in the back of that aircraft, irrespective if it's a training mission or an operational mission, irrespective of what service they came from, the back of that aircraft is full of everybody who's supposed to be in the back of that aircraft. And the front of that aircraft is full of everybody who's supposed to be in the front of that aircraft. And our job from the military health system is to make sure they're ready to do it from a medical perspective. We're not going to worry about the administrative parts or the legal parts, right? Services have those responsibilities. But from a medical perspective, where's all that operational readiness being maintained? It's inside the MTFs. And whether we're at the MTF or in the DHA headquarters or direct support cell, who's responsible for that? Well, that'd be us. On the right side of that photo, that surgical team, can you tell if that's an Air Force surgical team, a Navy surgical team, or an Army surgical team? Can you tell if that surgical team's in one of our MTFs here in America or if it's in an operational location? My guess is you can't, because they're not wearing uniforms, so I know on that one. And my guess is you can't tell where it is. Now, for full disclosure, the photo on the left, those are members of the 82nd Airborne at Fort Bragg, and it's the back of a C-130, and it's a training jump. On the right, that's an Air Force surgical team, and that's in Iraq. That's who we are. That's who we're supporting. So whether it's the readiness of the force or the readiness of our team, again, I'm a surgeon, so I got to pick a surgical picture. Doesn't matter. Could be a dental team, could be combat stress, could be anything. But that's what we're here to support, the readiness of all of that. And if you need a photo, you need an image to help you with it. This is the image that I use, but if you need something else, find the image that makes the most sense to you for how you do your job and what it means to the overall readiness of the force. Now, to get there, it's going to take some change, and I got that. Change is hard. So the image that I have now, for those of you watching, is an image that maybe some of you don't know, but when I was a kid, this is the way we listen to music. This is a record player, a turntable, phonograph. You pick the word that works for you. But when I was a kid, this is the only word. Turn on the radio, because I grew up relatively poor, so it's not like we're going to go to live music, but this is how it happened. Now, over time, change has happened, those of you who are my age or older, right? So we went into cassette tapes, took a sort of wrong turn into the 8-track tape, right? And then came back into, MP3s and now iPods and our smartphones and Apple Play and Spotify and you name it. That's what we have now, right? But the way that we've listened to music has changed over time. And in general, I think that's a good thing. Now, the cool kids tell me that actually these phonographs are making a comeback. So maybe you've seen some of those back, and in particular in the antique stores, there's actually a fair bit of these days. But here's the thing. When I go running, typically, I have my iPod still, because, I still haven't found the right backpack and a long enough extension cord to put this thing on my back. So while there is some benefit from the, Back to the Future kind of stuff, the retrograde, the antique, and the experience of music that you can get from a phonograph, there's still change that was helpful for us. Well, the same can be said about the military health system. Because really what we're after is taking this incredibly complex organization. And that's the next chart. Now, I love classical music, so for those of you who are looking at the charts and you're looking at why is he talking about this, because this is the kind of music I like to listen to. If you want to picture a country band, fine, picture it. If you want some rap group up there, picture that. I don't care. Whatever you like to listen to, picture that. But this is what I like to listen to. But here's the thing. Healthcare has grown incredibly complex, and that's why I think this photo of a symphony makes the most sense to me. Because in order for the musical experience to happen, not only do you have all kinds of different experts, whether that's in percussion or brass or strings or whatever it is, and different parts of them doing different things to make the beautiful music, how much of that also matters, right? If you have too much percussion, it ruins the symphony. Depending on what the symphony is, if you don't have enough strings, it ruins the symphony. But here's the other thing. For those of us in particular working here at the Defense Health Agency headquarters, or all of us in administrative jobs, this thing doesn't happen if you don't have what? Well, if you don't have, not just the conductor, if you don't have somebody setting up the chairs, if you don't have somebody buying the chairs, if you don't have somebody providing security at the place, if you don't have somebody selling tickets, advertising, if you don't have somebody taking tickets, right? If you don't have all of that, does this symphony happen? Well, maybe, but it would be a hot mess, right? So can it happen without? Sure. So let's talk about that. Can healthcare happen without administrative control, without standardization of process? Of course it can. And what does it look like? It's a mess. So the role of the administrative team isn't to boss around the symphony. The role of the administrative team is to provide everything such that we support it with just enough of that such that the music makes the most difference. That's our job. And ultimately, what do we do it for? Well, in healthcare, who's it for? It's for the patients. So in this particular photo that you're looking at, who's it for? It's for the audience, right? We don't do all that work, all that administrative back office work. We don't practice and perform for ourselves, even if sometimes we enjoy it that way. We can get some fulfillment just by doing it ourselves, but the fulfillment actually comes from the interaction with the intended audience, in this case, our patients. So again, if this metaphor works for you, then you know how I think this through. We are here to support the symphony. We're here to support the delivery of health care. But it better make sense. We better bring order to it. The standardization better make the experience better. And if it does, then we know about it. Because critics write reviews. Right? And we get those, whether they're in the Joe's survey, ICE comments, TRIS, information we get back from our staff. The critics write their reviews. And the critics matter to me. My hope is they matter to you. Now, ultimately, if you put all this together, what this is going to look like is the 4 priorities of the Defense Health Agency. So this is, I think, the last chart. So those of you who have it at your deck. And on the right side of that photo is you see a particular patient that I believe signifies why this all matters. Some of you may know this particular soldier, Sergeant Brandon Morocco. Hit quickly on his story for those of you who don't know him. He's an Army sergeant, was in an up-armored vehicle in northern Iraq in 2009. A shape-charged formed IED hits their vehicle. Everyone else in the vehicle is killed. He's the lone survivor. He's immediately taken care of at the battlefield through his resuscitation and journey out of Iraq through Germany back to America. He interacts with Navy medicine, Marine Corps medicine, so Navy medicine in support of the Marine Corps, Army medicine, Air Force medicine. He's engaged in immediate care, in Role 1 care, in Role 2 care, in Role 3 care, in Role 4 care, ultimately in Role 5, which is the long-term rehabilitation care. He touches every single part of our system. Now, the key elements. First living traumatic quadruple amputee. That's Brandon. So he spends about 3 months in our system. And ultimately, most of that time in 2009 is in Legacy Walter Reed Army Medical Center. About 5 years later, through partnerships, the last part of our system, through partnerships, because some of you are looking at this photo saying, look, Ron, I can see the dude's got arms. How could you possibly say he's a quadruple amputee? Because in 2014, he's the first recipient of a double arm transplant at Johns Hopkins University Health System as part of that partnership. Now, for those in the room, now you can't know Brandon. If you do, you can't answer the question. But where did he get his rehabilitation done after the double arm transplant? Walter Reed National Military Medical Center. And your answer to that, well, of course, I mean, he's a military beneficiary. We have that capability. Of course, he's going to do it there. But if only we weren't cheap, we'd let him do it at Hopkins. But here's the thing. Every arm transplant patient at Hopkins does their rehabilitation at Walter Reed. Because it's the center of excellence for the world for that. Now, for those of you who've seen I get a little bit emotional talking about Brandon. Every single element of our priorities are encapsulated in Brandon. I mean, he had to be ready to be a survivor of the vehicle when everybody else was killed. And think about the teams that were required. He's had hundreds of units of transfusions, too numerous to count surgical procedures. 10 years ago, he lives. 20 years ago, he dies. Our system can't handle him. That's the readiness of the medical force. And I promise you, you can see his smile on his face, with the exception of when he's doing physical therapy. This is the way that he looks every time. He is a satisfied patient. There is nobody who will speak more highly of you and the entire system than Brandon. Nobody. Similarly, I can tell you that every single person, at least that I've talked to, who's had anything to do with Brandon's care, is extraordinarily fulfilled in the work that they do. Again, if you need an image in your head about what our system means, Sergeant Brandon Morocco should give that to you. All right? That's the basics of what I wanted to talk to you about today. I know that there's lots of questions about things that are happening inside the military health system, things that are happening specifically within the DHA, things that are happening in partnerships with the service medical departments, things that are happening with COVID-19. Anything that's on your mind, I'm happy to answer the questions that you have.
Sir, I think we should go to the questions coming over Poll Everywhere, because a huge majority are on COVID-19, as you can imagine.
All right. I'll do my best.
It's a great concern for the workforce. The question that's voted the highest, if anyone knows how Poll Everywhere works, you can look at the questions and vote the ones that that are important to you. The question is actually about here in the DHHQ, but it could apply other places eventually. Since there's a confirmed case of COVID-19 in the DHHQ, when will telework be implemented, and how will that affect contractors?
So those who are telework eligible have telework capabilities now. And where it makes sense for our systems, then I'm fine with people using telework to do that. But the work has to be done. I mean, we're here for a reason. It's to support what's happening in the MTFs. And for those of you who are of a clinical background, I mean, they're walking into that every single day. Every single day. And so we have to be smart about it. Now, that said, there are ways to do that, right? There's cleaning capabilities that we have, and we're using them. In fact, we've updated our housekeeping contracts to make sure that the typical things that we want to do, like wiping down doors or allowing certain doors to be propped open so you don't have to handle the handle, put your hand on the handle, those sorts of things. But there's not an indication of people not coming to work based on the CDC guidelines. There's not. The work needs to be done. Now, from a contracting perspective, those that are mission essential, those are written into the contracts. Those that are not mission essential, they're not in the contract. So our expectation is that we and those that we contract with will fulfill the terms of the contract. If that needs to change for whatever reason, based on the latest news from the Centers for Disease Control and Prevention, then we'll do that. If there are particular things from a particular contractor that they want to change the terms of the contract, we'll listen to it. I mean, I'm interested in keeping us safe and secure, but I think I addressed that in my initial comments, and that is, be informed. And don't be scared for no reason. Be informed. Learn the best ways to keep yourself safe. And be smart. Now, I'm not an expert, as many of you know. I'm a general surgeon, so I'm not an expert on infectious diseases or preventive medicine techniques, but I do know this. I mean, every single place I go, people say two things, and those two things are what? Wash your hands. Yeah, don't touch your face, right? In particular, your mouth, your nose, and your eyes. But here's the thing. Man, I can tell you, I'm a guy, so men's restrooms are the only ones I go into. But I can tell you, men, that there are many people who go in the restroom who don't even wash their hands. Now, if that freaks some of you women out, I'm sorry. That's a fact. I'm also here to tell you there's a lot of men who put water on their hands and think that counts as washing. There's another cohort of men who put some soap in their hands, rub their palms together, rinse it off after about 4 seconds, and that counts as washing your hands. Ladies and gentlemen, I sent a video out for a reason, to help you learn how to wash your hands, because we live in such a safe society, even though our mothers particularly, but some of our fathers told us, hey, this is how you wash your hands. We didn't learn. But it involves soap on your hands for 20 seconds, touching all skin area of your hands to include the back of your hand. Because here's the thing, when you shake someone's hand, where does their thumb go? The back of your hand. When you're rubbing your nose, how do you rub your nose? Often with the back of your hand. So if all you're doing is rubbing a little bit of soap on the front of your hand and rinsing it off, how am I doing, Dr. Ireland? You're not washing your hands. So I'm just telling you, when I'm saying be smart, frequently wash your hands. Because I don't know about the rest of you, but while I've been standing here, most of you have touched your face. I just watched 4 of you do it just now. We can't stop doing it. Okay, so what's the solution to that then? Yeah, wash your hands or get some hand sanitizer. And if you're a type of person who likes to touch your face all the time, for whatever reason, keep the hair out of it, you got an itchy nose, whatever it is, get the hand sanitizer at your desk, put it on all the time. Because that's the deal. That's how we keep ourselves safe. Now, in terms of the danger of this isn't Ebola. Now, it's more infective. In other words, the likelihood of transmission is higher than Ebola. But the mortality of it isn't even in the neighborhood of Ebola. If you think of the avian flu in 2009, that's the general neighborhood that we're thinking here. Now, the denominator isn't high enough to know for sure what the mortality rate's going to be across all, right? So really old people with lots of medical problems, really young people, firstborn, kids, young adults, mature adults, hopefully I'm still in that, older adults without medical problems. We don't know nearly enough to really risk stratify across that. Am I doing okay still? Yeah? Okay. So we still don't know all those details, but this is not the end of the world kind of a virus. This is a be smart, be aware, keep your hands clean, and take care of business. And the fact of the matter is you still got to feed your family. And that involves going to the grocery store. Your children, those of you who have them, still have to learn because they're going to be adults someday. And this virus is not going away this week or likely this month. So this isn't a, man, all I have to do is shut this down for 10 days and all's going to be okay. That's not the way this is. So I know I've gone on a really long tangent based on the question that you asked, Ann, but that's my sense of where we're supposed to be going with this. Now, if you're sick, this isn't a, hey, you know, my boss wants me to come to work even when I'm sick. That's probably not good advice. Now this, hey, just don't come to work, is probably not good advice either. I mean, sometimes this virus can actually be kind of dangerous. And so if you're really sick, this is not just stay home. This is a contact somebody. For those of your military beneficiaries, that's what the nurse advice line is for. Giving advice, yeah, it's probably okay to stay home. Now I probably should go to the urgent care center. No, you sound 4+ sick. You need to go to the emergency department right now. For those of you who don't have the advantage of the military health system, you know, keep in contact with your primary care provider's office. And if you're really sick, make contact. That's all about being smart. So if you're sick, don't come to work. If you're sick, don't come to work. And those of us who aren't sick, we're going to carry the load for our brothers and sisters who are sick. And we're going to support the MTFs as they're supporting the force as part of the National Defense Strategy. So again, I know it's way bigger than the question that you asked me, Ann, but I hope that hit every aspect of it.
Another question, and it has to do with telework still, and this may be a supervisor-related question, not overall with the agency, but if there's not telework implemented across the agency, can an employee request telework without fear of retribution?
Yeah, of course. Well, that's my guidance, at least. If telework is capable, and I'll use an example. When I was the director of the National Capital Region, the Integrated Referral Management and Appointment Center, we had, I'm not going to say the number because I don't know if that's contractually a problem, but a whole bunch of people working together to do that at a particular location. And they came to me when I was the NCR director and said, hey, we'd like to telework. And of course, I'm a supervisor. My answer to that was, no, right? You got to come to work. I got to see the work that you're doing. And I said, okay, except that based on the work that we do, you can see exactly when I sign on. You can see exactly how many calls I take. You can see exactly how long it takes me to finish out those calls. You know exactly how many callbacks I get from that same number. You can monitor everything I do, no matter where I work. And, by the way, if I do it there, and we all agree to it that way, you can markedly eliminate or reduce the number of chairs that are necessary for us to have for the place of work. So it's going to cut your contracting costs for workstations and cleaning up and all that sort of thing. So we can save you some space too. Oh, okay, I can get to yes. So I'm just telling you, I'm okay with it. But the work has to be done. That's the issue. Because we're here to support. And if the work can be done to the same quality, to the same quantity, no matter where we work, then I'm good with it. But it can't be about us. It's got to be about getting the mission done. And the reason then to telework and getting the mission done is, well, if that helps keep me safer, if it decreases my risk of getting sick, then that's probably a good idea. But if I can't do the same amount of work and I can't do the same quality of work by teleworking, then if it's about the mission, then I'm going to have a hard time as a supervisor getting to yes on that. But supervisors, you have the authority to do that. I don't know exactly how low or how far in the organization that supervisory delegation is. But whatever our rules say, at whatever level of supervision, that's the guidance for supervisors. Okay? And you have more?
There are more, and they are COVID related.
All right.
Around the world, strong screening measures and diagnostic testing have been shown to mitigate the spread of COVID-19. How do you ensure that enough testing is done across the DHA? Are screening measures like temperature checks going to be done in DHA facilities?
Well, the answer to that is yes. Every DHA facility has been given the general guidance to follow the CDC guidelines. Now, the CDC guidelines are relatively routinely updated. As the CDC learns more and more about the character of this particular virus, they're updating their site. And so the guidance that we're giving is to do that. Now, there will likely be other methodologies of doing that, so I can give you an example. First thing this morning, a little bit of a surprise to us, the National Institute of Health put out guidance for their campus to restrict access to certain locations. And depending on if you're sick, not sick, these are the places that you could get onto the installation. The National Capital Region took that guidance, rapidly turned it around, and in another 22 minutes, that guidance will go into effect in MTFs here in the DC area. And what it'll mean is if you have this, that, or the other symptom, this is the location that you come in, you get checked first. If it fits the criteria, here's how we keep you separate. This is how we do the testing. This is how you find out, et cetera. If you don't have those things, here's where patients come in. By the way, it's still a little bit controlled access. And if you're not a patient and you don't have those, here's the place that employees come in. So we're not mixing and matching people who may be coming with their, certain symptoms with the general population, in particular the healthcare delivery team, because we want to keep them as safe as possible. So my expectation is you may see some guidance for the entire military health system about consideration. I don't think it'll be mandated by me, at least in the short term, but consideration of access control, and does that make sense for your particular location? We don't have any new access control plans for this particular campus. Why is that? Because if you're sick, don't come to work. And if that means the rest of us aren't healthcare delivery people and we're all admin people, that means we're all coming in the same places anyway, and it shouldn't matter for us. Okay?
Are there contingency plans for supply chain disruptions of medical supplies, most of which seem to be primarily manufactured in China?
Well, so I'm not the guy to answer that question. The United States Congress is wrestling with that. I don't know if we're going to get any legislation about that. I think all of you know currently there is no American law that restricts or not the active pharmaceutical ingredients, for example, or where particular disposable medical equipment, et cetera, is manufactured. There are no rules about that. There are no laws about that. So it's all market effects. The Congress is interested enough in this particular situation that there may be legislation that comes. I'm not suggesting that I know anything about it. I just know that we've been asked to testify, we, the DHA, we've been asked to testify about that particular situation a couple of times over the last, Mr. Priest, twice over the last year or so? Okay, so the person who's carrying the water for us is Mr. Chris Priest. He's been over there a couple of times. I think the first time was March or April of last year. And then he's going back again early next week to do the same. So there may be guidance coming out of it. Our stockpiles of those particular things are relatively robust. I'm not going to get into how robust they are because that's on a relatively need to know and a relatively classified situation. But you should know that your government, and specifically the Department of Defense, has thought about this before, and there are wartime stocks. And they are relatively robust. So for the care of the Department of Defense, you should feel confident that we have significant capability to take care of the entire Department of Defense for a relatively significant amount of time. Now, some of the things like testing, and Ann, I think that was part of the last question that I didn't answer very well. There are currently, unless things change this morning, Mark, 13 labs across the DoD. Is it still 13? Still 13? Okay. 13 labs. There's 3 labs that are in the testing process to see if they may be laboratories within the DoD that can still do this particular assay. We've also put an ask out for any MTF that has the particular tool, and the tool is a reverse transcriptase polymerase chain reaction test, so RT-PCR, easier for me to say. And we know already that there's more of them, and we'll be asking for all of our labs to have that capability. The reason for that, it reduces the turnaround time from the time the specimen is taken from a particular patient until you have the message or the results of that particular study. The numbers of assays across the United States is relatively small at present. the numbers of assays that should be present around the United States within the next week will be in the 7 digits. So relatively limited now. The manufacturer tells us that that will be changing with truly hundreds of thousands of assay kits in the next several days to maybe a week. Those of you who know more about this than I do, is there any detail that I left off on that particular answer? Mark or Joe Payne? Oh, yeah. Asymptomatic versus symptomatic. Results so far are showing pretty clearly that testing asymptomatic people is a waste of time and money. That it doesn't mean, even if you've been exposed, doesn't mean you're not infected. It just means that you're not expressing the virus. And that can give you a false sense of security. So if you're not symptomatic and we test you, it very easily can be a false positive. The only people that so far information, at least with the testing that we have currently available, the only people that we should be testing are those who are having symptoms. Nothing else? Okay, Ann.
I don't know if there are any questions here in the room. We'll go back to the questions that are coming in through Poll Everywhere, but I also wanted to give an opportunity to anyone on VTC who has a question. I'll go on and address one more, and then the next one will go to VTC to see if they have questions.
All right.
There seems to be concern that if we have a significant number of people teleworking, our network cannot support that. Is there a plan to mitigate that?
Yeah, I'm not seeing Mr. Flanders in the room. The information that, Dan, you want to answer that? My current understanding is our system can handle a pretty robust load. And so my current belief is with a significant amount of our staff teleworking, the bandwidth that we have will actually be able to carry that load. That said, not everybody has to use VPN. What's the other place called? Web Access. Yeah, the Outlook Web Access is really, for those of us who don't need access to the drives, you get the same cybersecurity if you just use Web Access. So if you need access to your drives to get documents off your drives, then the VPN's a good place for you. But if you don't need that, it's actually faster if you just use the Outlook Web Access. And if we need to put out the right way to get there, then I'm happy to have our information operations team do that. But first, we should have plenty of bandwidth in the VPN, and for those of us who don't need it, using your home router, but Outlook Web Access is the way to go. But Dan, can you remind me to send out the link? Okay, thanks.
And do we have anyone in our VTC sites who has a question? You can unmute your button and ask it, please. I'm not hearing anything.
Was it Captain Case? Matt, if you're talking, I can't hear you.
I wasn't, sir, but hello.
Okay, good morning to you.
Jacksonville. Yes, sir, I do have how about a non-coronavirus question?
I'd love it.
All right. I've gotten some mailers recently that we're getting about burn pits that have come through health.mil. And they're going, my 16-year-old daughter got that she may be eligible for a register for burn pits, and it looks like it's coming through OSD, maybe through the readiness division. And now I've got another spouse that's gotten one on our staff. So do you know, is DHA aware of this publicity, that mailers that have gone out, and do you know kind of who they're targeting? I mean, I would understand if they're targeting me for being in Afghanistan, but my 16-year-old daughter in burn pits probably isn't applicable.
Yeah, I'm aware of the congressional requirement for the burn pits, but I'm not aware of the mailers. Mark, do you know? Yeah, but they need to hear you out there, too. I'll make sure that he can hear, so won't use my microphone.
Okay, sorry. Hi, Captain Case.
heard
It's
it.
Gina. How are you? And
Gina, good.
so we will check on why the letters went to the wrong people. We were ready for those letters to come out for patients who wanted to have a regular exam. Colonel Svaitaj is the lead for that for the military health system, but the team that sent out the letters were from OSD. So I will double check with them today and see what we can do to rectify that. Over.
Great, thank you.
Anything else, Mark? Okay.
All right, we're going to go back to our questions until someone in the room has a question. Talk is there'll be no civilian replacement for military billets that have been cut, so we'll be doing more with less. How's the DHA fulfilling its own mission of increased readiness, better health, and better care with these changes?
Okay, so that's a great question. So it's really bringing together several different transformational changes, the first of which is the Department of Defense evaluation of what's the right size of the uniformed medical capability. And based on that decision, that it's likely more important to have people doing other things like more squadrons in the Air Force and more ships in the Navy and security forces, assistance brigades in the Army, et cetera. They want to build those, and because of that, the uniform medical staff will be less. Similarly, there was a requirement for the department to evaluate the facility infrastructure for what's required to obtain and sustain full readiness capabilities for our uniformed service members, as well as obtain and sustain readiness for our deployable medical teams. And based on that analysis, there was a decision by the department that likely required less. And so both of those things have to be worked together to make sure that whatever cuts are coming from the uniform is also rationalized across what places may be getting smaller. So all that's done collaboratively. That work is being done now. There's some reporting requirements back to the department in particular for the uniform manpower reduction. The requirement is to have that back to them by sometime in the middle of June. There's a specific date. There's a possibility that may be done sooner. Similarly, there's a requirement for, in the development of the budget, for us to have information back to certain committees on the Congress about what our plans are for reduction of facility space across the MTFs that were considered, for example, to go from full outpatient clinics to active duty and occupational health only. So that work is happening, and that's really detailed work. Now, from a facility standpoint, that will probably take years to do, to be able to transition enrolled beneficiaries from our system into the network. And in some cases, the network, even with knowledge that it's coming, may not be able to build it, and that may change the direction of our plans. But all that's happening. Similarly, then, we have to be able to figure out what are the deltas and what needs to be filled with what sort of non-military staff. In some cases, it may be civilian staff. In some cases, it may be contract staff. In some cases, it may be at this particular location, because it's going from a full-spectrum outpatient clinic to active duty only, there are civilian employees that may be impacted that will be giving opportunities to move to other places that we have a need for civilian staff members, for example. So that whole process is an integrated, I don't know, it all works together. Can't pronounce the word. It all works together. And so rather than attacking each of these things individually, we're looking at it as a single consolidated plan to have the right staff at the right place to do the right mission in support of the National Defense Strategy. So I don't have more details than that for whoever asked the question or in the poll everywhere, all the people who are answering the question. But that's the plan to get to the answer to the question. Was there a piece of it that I didn't answer, Ann? Okay. Anybody in the room? You like hearing Ann talk? Is that the deal? Yeah? Everybody's nodding, Ann, I guess?
I guess so. We can take a question that was asked ahead of time.
Sure.
How How will the inclusion of multi-service markets and MTFs transitioning to active duty-only clinics affect the current workforce, if at all?
Well, yeah, I think I got into that pretty much with the way I answered the last question. I do think it's going to impact some of our staff. Because if you're working at an outpatient clinic that right now is, you know, the whole wide variety of all beneficiary categories in outpatient, and it becomes active duty and occupational health only, then the scope of what's going to be required there is going to be much less. If you look across the military health system, though, some of our clinics have very few civilian staff in them, and that would largely be Air Force clinics. Some clinics have an awful lot of civilians in them. That would be the Army clinics. And some are kind of halfway in between, and that would be the Navy clinics. And so depending on what's required and how much civilian staff is at a particular location, different locations may have different effects from this transformation and transition of different clinics. And that all will be part of the plan. And my personal guidance to our team is if our decision-making negatively impacts one of our civilian staff who still wants to be on our team, to find a way to move them to a different location so they can continue to serve as a civilian. And we'll do everything that legally we can do to make that happen. Right? Legally we can do. Okay.
Will DHA make it a standard practice to credential MTF providers across service lines?
So let's make sure we're talking about the same things. Credentialing and privileging are two different functions. Credentialing is the stuff that you bring. So your degree from your school, your certificate from this training, that's certification. And the requirements that we have statutorily, as well as DoD policy, is primary source verification of credentials. We believe that we can standardize that and centralize that so that once that credential is verified within the military health system, we don't have to verify it ever again. So those of you who know about that now know that every time you PCS, you got to redo the primary source verification of every single credential that you have. Well, we see that as a pretty extraordinary waste of time and effort. But privileging, so that's what you asked for. So as a general surgeon, I asked for the privilege to operate on people. And specifically, I asked for the privilege to do these types of operations for people. So privileging will always stay local. That's a requirement from the Joint Commission, that whoever's responsible for the care that's happening in that building is the privileging authority. So centralized credentialing, continued distributed privileging is the way ahead for the Defense Health Agency. I do okay, Dr. Kortz? Okay.
Do you foresee a knowledge management officer role in the DHA in the near future?
Yes. One of the things that I think we were a little bit challenged with is the effective utilization of knowledge management capabilities. Now, I don't know what our knowledge management is going to look like in the out years, but I do know this, that as we're bringing together really 4 cultures, and by DHA, maybe not DHA culture, but certainly TMA culture, which is the basis of the DHA culture, and Navy medicine culture and Army medicine culture and Air Force medicine culture, bringing all those together requires the capability of knowledge management. So yes is the short-term answer. What it looks like in the long term, I don't know, but we'll have it, and I believe it'll be useful for us as we manage our system. Yes, ma'am. Thanks for being brave.
Thank you. So I'm just wondering, sir, my name's Kimberly Ellenberg. I work for Colonel Ireland and Combat Support Agency. The question I'm wondering is, when we talked about having a medically ready force, and we know that they're being exposed now potentially to COVID-19, right? So are we able to identify those who are impacted and how long we project they're down, what their knowledge, skills, and abilities are, and that force structure with the other readiness data that's captured in DERS, so that we truly know what our operational capability and capacity is for the national strategic planning? Likewise, equipment, right, because that's also captured in DERS. So if supply chain demand is impacted, right, are we doing an exercise with readiness, combining our health intelligence data with readiness, so we're informing that?
Yeah, so that's a great question. So here's the challenge, though. At an individual location, it's probably okay to release that information. gathered up collectively across the military health system has national strategic implications associated with it. So we'll never make that available in an environment like this.
Yes, sir,
So if you're asking, is that work being done? That work is being done. I promise you, that work is being done. And the National Command Authority has been very specific about what they're interested in to help in their decision making. And we're providing that information to the National Command Authority.
Good morning, team. Good morning, sir. Mr. Johnson from Military Personnel Support Branch. I have a quick question. In response to COVID, is there any projected hiring freezes that you can foresee, particularly for contractors who are seeking to integrate into the civilian sector?
I'm not anticipating any changes. Our mission continues. So whether it's civilian staff, no, I'm not anticipating any hiring. And for those of you involved in the transfer of function for members from the service medical headquarters, that's going to continue. We are still anticipating delegated authority for the mandatory reassignment authorities that were part of the National Defense Authorization Act of 2020 to be delegated to somewhere in the military health system. And then once that delegated authority is achieved, I anticipate that we will use that authority to move people from Army medicine, Navy medicine, and Air Force medicine where the services want to, and we'll find positions for them in the Defense Health Agency. So let me make all of you comfortable with the idea that it doesn't matter what the work is, healthcare work, administrative work, it is going to go on. Okay? Yeah, thanks. Anything else in the room? Okay, keep your thinking caps on. And back to you.
How's the DHA supporting our troops and families in Japan, Korea, and Italy? I'm assuming this is COVID-19 related, since those are where some of the outbreaks have happened.
So that gets a little bit sticky. In the agreements that we have with the service medical departments, we collectively agree that the focus of the Defense Health Agency is in the United States. And so almost all of our efforts to date have been U.S.-based military medical treatment facilities. That's not to say that we're not in communication with OCONUS surgeons, for example, and that not that we're not in communication with the service medical departments about the requirements for OCONUS locations, but they continue to be in the lead there, and we're in support. So that's the answer. If the services are asking for a particular capability, a particular type of support in Italy or in South Korea in particular, then we'll do everything that we can, again, legally and according to policy, that we can to support. But they are the supported, we are the supporting organization for OCONUS.
One of the questions has to do with some data. See if we've collected some data on how many COVID-19 tests have been administered in MTFs and how many are positive, and how will the, I don't know what this is, sorry, unstable MIP platform affect surveillance of COVID-19?
Unstable MIP platform.
MIP.
Okay, I don't know what that means, but I want to be a little bit vague about this. Again, in the roll-up, there are national strategic implications, so I'm not going to give specific details. I will say this, we've done in the hundreds of tests. There is a less than 2 handfuls of U.S. military beneficiaries of any type who have tested positive. In the National Capital Region, there is less than 1 handful of DoD beneficiaries who have tested positive. So it's small, but it's real. So again, be informed, be vigilant, and be smart. And wash your hands. Mark, I'm trying.
What is the transition plan for public health commands?
So that's a great question. The 2019 National Defense Authorization Act gave very specific guidance about how public health systems within the similar outcomes. Now, I said similar on purpose. There's nothing like being present, and I get that. So then it's a balance of risk to mission, risk to force by being present versus risk to mission and risk to force by using a different technique or technology to achieve that goal. And that's really what we want to be able to balance. Again, we have to be smart about it. Now, same sort of guidance, and I see Miss Julian, looks like she stepped out. I gave her the same sort of guidance for the way we manage our templates. There's certain healthcare that just by our habits that we've done in person, because that's the way we've always done it, that may be able to be done using other technologies, whether that's video chatting, whether that's just using the telephone, whether it's secure messaging. But to relook at some of these things, is there true value in presence in the healthcare delivery as well? And if not, is there ways for us to do it a different way, knowing that the bean counters, right, the workload generated will be different and likely less. But if that decreases the risk to mission and risk to force, is it worth earning less to be able to continue to do that? So we're trying to balance both of those, both from administrative travel requirements as well as the travel requirements for patients to come in to see us. So when you said travel, I think you meant our official duty travel, but I mean all travel. And evaluating what's the advantage of the travel versus what's the risk of the travel. Questions in the room? Y'all are normally way more talkative than this.
And sir, I want to explain to some of the folks online who are asking questions. If we have 20 questions about telework, we're hiding most of them because we've already addressed it. So we're not intentionally not answering a question about telework. It's just we're not going to keep asking the same question. So I want to assure people we're not ignoring their question. Right now, the one with the highest number of votes, with 82 votes. Other agencies, private companies are being proactive, eliminating self-service food options, canceling in-person events, limiting visitors, testing telework for all employees, etc. Why is the DHA handling and I'm assuming here in the DHHQ, the presumptive COVID-19 case differently from other agencies and private companies?
Yeah, so that's making an assumption about facts that are not present. The Defense Health Agency, and specifically decision makers in the Defense Health Headquarters, are using the same criteria that the CDC has published for everyone. So it may be that things are happening that you don't know about, but we're using the same rules for every other organization. Now, will that mean that there'll be changes to the cafeteria out here? It may well mean that there will be some changes to the cafeteria. But everything that we're doing, every decision that we're making is being fully informed by the latest and greatest information that's updated relatively routinely on the CDC webpage. So if somebody has specific knowledge where they think that we're making decisions that are different from that, then contact your supervisor or your supervisor's supervisor, and we'll work through the details. Because that's the guidance that I think every supervisor is giving, that we're going to follow the CDC guidelines. So to all 82 of you who voted for that, those are the rules.
It's evident to some that there should be a town hall dedicated to COVID-19. Seems like this one is becoming a little bit of that already. Can you implement that? People aren't receiving the information they need.
Well, yeah, okay. So this is the balance of enough information with too much information. Again, I want everybody to be informed, which is why I think you've received more information from me about this particular topic in the last 10 days than you received on any other topic that I've ever sent any information on. But it's an attempt to balance the right amount of information and the right type of information with not overloading what you're doing. and we're going to continue to do that. Now, everything that comes over my signature block is vetted with subject matter experts. Now, believe me, every single word of that is read by me, I think my staff will tell you that every single thing they sent me gets changed by me because I want it in my voice to explain what I think is important, to include always going back to the National Defense Strategy and always going back to the patients that we support. Always. Always. Now, we're going to be smart about things, but I don't want people spending their entire workday thinking about this on the internet, trying to learn from the internet. It's not the right way to learn about it. But the CD website's not updated every hour. If you've read the CDC site once a day, I'm telling you, you've read everything you're going to learn. And stay off the mainstream media. Remember, that's a business, ladies and gentlemen. Now, whatever news station you like to listen to, TV, podcast, whatever, good for you. Get your information politically where you want to get it. But that's not the right place to get medical information. It's not. So stop reading it. Unless it's for entertainment purposes. Because, I mean, they're in a business of entertaining you, and if that's how they can entertain you is by shocking you and wanting you to do that, good for them. And if you enjoy that, good for you. But don't think that you're going to get medical information there. It's not the right place. And you're taking time away from your important duties. CDC is the only site. It's the one that we have on our webpage. Just go to that. Mr. Zemp, do you have more to add to that?
Sir, if I can. So we've, in the last 10 days, we've released 2 all-agency messages. The first one concerned telework and what you need to do to implement situational telework if you haven't done so before and you're not prepared for this, what you could have been doing this last week and a half to get prepared for it. That's out there. If you need more of it, we're the proponent for telework policy, and we can help you with that. The second thing is that we released a message that gave employees and supervisors the tools that they can use in terms of different leave status, what latitude they have that already exist in terms of, what you can and can't do in terms of people and if they exhibit this or that. Basic guidance on, as the boss has already talked about, washing your hands, right? Watching out for your teammates, going and getting checked immediately instead of coming to work. That's all been out there on all agency messages. Again, if you're not seeing that from your supervisors, come back and let us know. We're also happy to re-release it. If you have any questions about telework or the like, you can also bring those our way just on a daily basis as well. You don't need to wait for a town hall to do it.
Yeah, now
Sure.
Secondarily to that, as I said, I think we put out more information about this than any other topic that we've had since I've been in the DHA, not just in the director, but since I've been in the DHA, so now a little over 3 years. That said, this probably isn't going to be the last town hall we have about it. Probably not. I anticipate that other things will happen. I anticipate there will be more positive diagnoses across the military health system. I anticipate more positives within this building. I anticipate we'll have more discussions on it. I don't think it'll be, the next time we have a town hall, probably not going to be quarterly. It probably will be another update about this particular topic. When that's going to happen, don't know, because it'll be conditions-driven, not time-driven. So I'm open to that idea, because I get it, man. This is scary. And so when I'm talking about being smart and thinking it through and learning, this can kill people. But, so can influenza. And in particular this year, it's a way higher ratio of influenza A, which typically is a worse influenza than influenza B subtypes. But none of you know that, except the public health people here who follow this stuff because that's their cool thing. But most of us don't know that. And as a trauma guy, I know how many people die in car crashes every year in America as well. It's in the neighborhood of 25,000. And yet we're not having a town hall about knuckleheads who are drunk driving. I'm telling you, 500,000 people die from complications of tobacco use every year in America, including our brothers and sisters who work in this building. We're not having a town hall about tobacco use. So, again, I'm not diminishing that the fact that this bug can kill you, but it'll be uncommon, in particular, if you're not relatively old with modest to significant medical problems. If you're younger with no medical problems, the risk to you is pretty low, but not zero. So be informed, know your risks, use those risks to help you in your decision making. We're going to get through this together. And if that takes another town hall in a few days or a couple of weeks or whatever, then we'll do that, specifically to that question.
Non-COVID question. Will the Space Force have a medical component, and will they join DHA?
Yeah. So for all the cool guys in the Air Force, the answer to that is probably yes and yes, but way too early to be able to tell. Now, a lot of options on the table, so before I've really flummoxed some of our Air Force staff, one of the options is, and I think the option that will be chosen, by the way, but not my decision, clearly not my decision, but just like the Surgeon General of the Navy is also the Surgeon General for the Marine Corps, I believe the option that will be maintained, the current option, is that the Surgeon General of the Air Force will also be the Surgeon General for the Space Force. That's what I believe is going to happen. And in terms of interactions, if there are locations, if there are installations that are Space Force locations, and they have an MTF on them, then yes, the DHA will be involved in healthcare at Space Force locations. Any Air Force leaders disagree with what I just said? Okay.
When will the civilians who are coming under DHA become DOD civilians?
So that process has started. There are 298 mostly Department of the Army, but some Department of the Air Force and Department of the Navy civilians who are in phase 1 and 2 of the transfer of function requirements. So this is the headquarters functions. They are all in a stepwise process of transition. I don't think any of them have completed it yet. Is that right? Or have some completed it? Phase 2 is complete? Okay. So all 298 then are complete? Oh, I didn't know that. All right. So 298 have transitioned from, again, mostly the Department of the Army, but Department of the Navy and Air Force civilians in our headquarters to be Department of Defense civilians. Ultimately, all who are part of the Defense Health Agency will transition to becoming Department of Defense civilians. That includes civilian personnel who are working inside MTFs, doing healthcare delivery. Now, if there are people at installations that their services have decided and moved into a readiness billet, they will maintain their capability as a Department of the Army, Department of the Navy, Department of the Air Force civilian in support of service readiness. But everybody who's in the healthcare delivery side, working in the MTFs, doing our mission, ultimately all will transition into becoming Department of Defense civilians. That process has been worked out. We have a memorandum of agreement with the Army's Civilian Human Resources Agency to be the civilian personnel resourcing organization to help us with that process. Those first 298 have gone relatively well. We learned some things in that first tranche that as the third phase starts next week, we believe will go even smoother than the first two. And that's just for the headquarters. And then we'll use those same sorts of... We lost Davids, huh? No? Okay.
You are entering the meeting now.
We didn't lose divots. We lost the VPN connections. VTC connections, so they're pulling it back up, sir.
Okay. At any rate, all that civilian personnel work is ongoing. We anticipate it will take at least this calendar year to work through all of the process. And it may well...
Sorry, sir.
This is why we don't want to do everything virtually. It's just not the same. At any rate, at least this calendar year to work through all of this process. I wouldn't be surprised if it didn't bleed into the next calendar year as well, but it shouldn't take a whole lot longer than that, assuming the management-directed reassignment authorities are delegated relatively quickly, and the process by which we transition the MTFs, of which the first phase of that will happen in the relatively near future, goes the way that we anticipate it going. If it doesn't go as well as we think it's going to go, then we'll learn from it, and I'll come back to you with more current information after we work through the first part of the MTF part. Anything else? No? Okay. Yes, ma'am. Okay, she's bringing it here. Okay.
I'm going to ask you anyways, representing the dental community.
Yeah.
And I've read the CDC guidelines, and I really want to thank the U.S. Army Public Health Command for giving some additional guidance for our DTFs. Because as you know, our dentists are working in an aerosol generating environment. And so the recommendation from CDC is to work in some of these aerosol infection isolation rooms, which our dental clinics are not designed for. And so some countries like Italy and in South Korea have resorted to just providing emergency treatment, although some of those emergency treatment are also aerosol generating. I get it, we'll be smart, we're going to wear our PPE, we're going to not treat sick patients, let them get their medical care and so forth. But do you believe now that we have ADC of DTFs in CONUS, do we need to provide additional guidance from DHA? Do I need to draft some kind of memo and have DADMA and Rear Admiral Riggs sign or from you? Because I know these questions are going to come up to me eventually.
Yeah, so the challenge that we have, there's going to be some balance associated with it. Our DTFs are readiness enablers. Some of the healthcare that we deliver is for family members, which are readiness support enablers. Some of it is for retirees and retiree family members, which is not readiness associated. But the huge majority of the work that we do inside the DTFs is readiness associated. So I can envision a time where the risk is high enough that we will be strongly considering going in that direction. I don't think we're there yet, though. But to your point, though, and I'm glad that you brought it up, thinking through what's the trigger for that, how do we make those decisions, at what point do we say this is the way, again, risk to mission versus risk to force. Right now, the risk to mission is higher, got to keep the work up. At some point, the risk to force may be significantly higher, where we say, nope, it's time to stop doing that. Here's the conditions that would be required for us to start doing it again until we have the capabilities inside the DTFs as you described. But not yet. But your point is well taken. I hadn't thought through exactly through that. Let's work together to draft up what are the trigger points. At what point would we put that guidance out, okay? So the answer is yes, but we're not going to execute it yet. But let's think through how we would do it.
We have a question online. It has to do with COVID-19 and being airborne, which I think might be an opportunity to correct that, because I don't believe it is spread through airborne transmission. It's the droplets.
Well, yeah, droplets are airborne, though. So bodily fluids is just good general advice. As a proctologist, when I think of bodily fluids, I think of different things than most of you think about when it comes to bodily fluids. But it's all bodily fluids. So, again, one of the reasons for washing your hands after you use the restroom, it's bodily fluids. That's where the virus lives. And so if you're expectorating, right, coughing, sneezing, that's why you cover your mouth with your sleeve. Or if you're going to use a tissue, then you cover your whole mouth and you throw the tissue away. And then what do? You wash your hands. Or you get the hand sanitizer, it's got 60% alcohol, and you make sure every single part of your skin is covered and it dries before you do anything else with it, because it's the drying of the alcohol that kills the virus. Right? Yeah, so if you just put it on and your hands are all wet and you're shaking hands, you're still not clean. I'm telling you, ladies and gentlemen, if we just listened to our mom when we were kids, we'd be in a whole lot better shape than we are now. And those of you our moms, man, if you're not hammering this home with your children, and those of you who are particular single dads or dads who have that primary hygiene responsibility with your children, if you're not hammering that home, now's your opportunity.
I want to give one more opportunity to VTCs to ask a question, because we're just going to do one more question, and then you'll have time for closing remarks, sir.
Okay.
So anyone in VTC have a question? You can unmute your mic. And anyone in the room have a question? So we'll go to one last question online. What will essential personnel do when there's an outbreak in their work area, such as lab personnel? So we're talking like in an MTF, not in the headquarters building.
So the answer really is for every area. It's the balance between risk to mission versus risk to force. And those are military terms, I get that. But it's what's the importance of the work that we're doing versus what's the danger to the people that are doing the work. And the more important the mission is that must be done, then the higher amount of risk that we're going to accept for the people. And I can tell you, I was in the Fort Belvoir Community Hospital laboratory yesterday, and I've been in lots of labs in my time as a physician in the Army, and I've been in lots of labs in my time as the director of the National Capital Region, and now as the director of the DHA as part of the DHA. And I've never seen a more motivated group of laboratory professionals than what I saw yesterday in Fort Belvoir Community Hospital's lab. And they're all decked out in their personal protective gear, and they're sweating a little bit because if you've worn an N95 mask for a while, you know that it's not the easiest thing to do, and they're wearing it all day. And they are pumped that what they're doing is so important. Pumped. That's the way I think we ought to be. So I'm going to actually roll this into my closing comments. This is not business as usual. I get all that. If you haven't heard that from me so far, then I've been a failure as a communicator. There's risks associated with our transition. And there's risks associated with COVID-19. There are risks. And we need to learn about things that are happening in the transition, both collectively and how it impacts us individually, hence the civilian personnel questions, I think. I get all that. There are risks associated with COVID-19. We got to be smart about it. What are my personal risk factors? What are my occupational risk factors? How do I balance all those things out? But we're part of the Department of Defense. We are in support of the national defense of the United States. That's our job. Now, for all of us who wear the uniform and all of us who at one point wore the uniform, then you know exactly what I'm talking about. We signed up for this, and these are some of the risks that are associated with our mission. And I get it, life circumstances change. So if any of us think, hey, I signed up for a different mission, it's time for me to do something else that has less risk associated with it, okay, I get that. That's the reason some of us were in uniform and decided to get out of uniform. That happens in a person's life. But our mission hasn't changed. And I pledge every ounce of my awake time. And so far, in the last 10 days or so, there hadn't been a whole lot of awake time that wasn't associated with doing this work. Every moment of my awake time to try to make decisions that optimize our forces, minimize the risk to the force, so that that mission can happen. And if there are better ways for us to do it, then you brainiacs help me with it, because I don't, there's lots about this that I don't know. And if there are better ways for us to keep ourselves safe, then let's do that. If there are better ways to organize ourselves that improves our mission and decreases our risk, let's do that. If there are technologies available that enable us to do our mission and decrease our risk, let's do that. But let's do that collaboratively. But let's not do it as a selfish thing, as if it's all about me, but let's do it as a way that is good for all of us. And ultimately, when our brothers and sisters, and for my personal example, when my children are on the DMZ, we're still going to support them. And just because there's a new risk in the world, that we don't just fold up our tent and say, we're going to go home. We're going to be smart. We're going to be informed. We're not going to be complacent. And we're going to work together. And as new information comes, because of our resilience, which is kind of a throwaway word a lot of the time, but because of our resilience, because of the way that we work as a team, we're going to be successful. Now, as I mentioned before, some are going to be sick. My guess is that some of us in the Department of Defense, the 2 million of us, some of us are going to die. Similar to the way that some of us have heart attacks and die. Some of us lose our battle with cancer and die. Some of us lose our battle with age and die. And we're going to wrap our arms around, figuratively, not literally, wrap our arms around them and help them through it, the families, the coworkers, etc. But our mission will go on because that's who we are. Now, again, I don't know when the next town hall is going to be, the next communication. My guess is the next communication you get from me is going to be another email that's going to describe whatever's new. And as the amount of changes mount, then we'll relatively quickly establish a time frame for another town hall. But I wouldn't anticipate it next week. My anticipation of what we're going to do is just work for a while. But as early as perhaps another couple of weeks from now, I'm open to the opportunity for having another conversation. And then finally, as I mentioned, from my wife and from me, as parents of uniformed service members, thanks for what you're doing. And there's some courage involved in all this. But if you look at in this building, and if you look at our MTFs, the number of call-outs for sickness is actually below our usual average. Think about that for a second. There is courage involved with this. You have it. Thanks for doing it. And until next time we talk, keep up the mission. Thanks, everybody. Carry on. If anybody else have any questions that they didn't want to ask in front of anybody else, I'll be up here in the front. Feel free to come up and chat with me.